Today we are tackling a case of lower right third molar extraction with 8 of radiograph. It is very difficult. You can notice from the radiograph. Number 1, it is restored lower 8 by amalgam restoration, which means it's functional tooth. Missed lower 6, which means it carries much load than usual. Opposed by upper 8, very difficult. It sustains more occlusal force, intimate contact between the bone and the root, which means it will be very difficult in luxation. Also resorption of mesial interdental bone, mesial to lower 8, which means I lost the fulcrum for liver. For this reason I decide for forceps extraction, but it's very difficult due to accessibility, due to upper 8 eruption coupled with limited jaw opening of the patient. I hold the tooth along its long axis, mesially tilted. I try to luxate apical rotatory movement, deep wedge, and push the top of the forceps by thumb of non-dominant hand to take a deep grip. But I felt resistance at this moment. I feel resistance, so I decide to stop working by forceps and shift to elevator. Searching for any method for luxation of this tooth due to its difficult inaccessibility by forceps, as well as difficult in luxation by elevator. But I feel some progression like this, but it's unusual. This is called interpretation of the finding and interaction with it. I place my thumb of non-dominant hand on occlusal surface to assess the luxation. Is it luxated or not? From buccal side, I decide to assess is it luxated or not. Maybe this is a buccal curvature of the root will not appear in radiograph. I try with little help, no progression of this case, so I shift my mind from the extraction of this tooth to gain much luxation as much as you possible. You have to change your mind at this moment. If you feel any resistance to gain any luxation. For this reason, if it fractured, the fractured part will be luxated, which means it will be easy in extraction by elevator. For this reason I shifted from forceps to elevator, and from the elevator to the forceps, and from the forceps to elevator, searching for any luxation to luxate the tooth, trying to gain luxation. You can notice my thumb of non-dominant hand on the occlusal surface of the tooth to assess the luxation range. Searching for any luxation, you have to wait and be delicate, and no need to hurry. Just be delicate and assess what is going on for this tooth. I try to luxate it from the mesial side as well as from buccal side to assess is it intimate contact between the bone and the tooth, or there's curvature of the tooth roots into the buccal direction or lingual direction. And finally I felt luxation from this side, so I place my thumb of non-dominant hand on occlusal surface to gain as much luxation as possible without fracturing this tooth. You can notice this blood means it is luxated. As you see blood, it is luxated. As you see blood, it is luxated. For this reason, I shifted to forceps extraction. Let's see what's going on. My thumb of non-dominant hand push the forceps apically as much as possible. You can see it is luxated and going to be extracted. But fortunately, not unfortunately, fortunately, it fractured. As despite it is fractured, but it is with luxated fractured part, which will be easy in extraction by elevators. For this reason, I shifted to a socket applicator, which should be placed in the mesial socket. But pay attention not to push the tip of the elevator at this side much more apically, because it is lower 8. You cannot see the inferior alveolar nerve, which is the difference between the socket applicator in lower 8 and lower 6. And finally, it removed. Your comments will be appreciated. I speak slowly for non-English speakers.